This lesson is crucial as it forms the very bedrock of effective emergency medical care, patient assessment. As EMS professionals, you are the critical link in the chain of survival, often the first medical eyes and hands on scene. Your ability to rapidly and accurately assess a patient's condition, identify immediate threats, and formulate a working diagnosis under pressure directly dictates the subsequent care and ultimately, the outcome for those in need. In this lesson, we'll delve into systematic approaches, key considerations, and practical techniques to hone your assessment skills, ensuring you can confidently and competently manage a wide range of medical and trauma emergencies you'll encounter in the field. Upon arrival at an emergency scene, the absolute paramount first step for any EMS provider initiating the primary assessment is the immediate formation of a comprehensive general impression of the patient. This critical process unfolds almost instantaneously, often within the initial few fleeting seconds of visual contact. It's far more than a cursory glance. It's a rapid, multifaceted evaluation that sets the stage for all subsequent assessment and treatment. During this initial observation, the astute EMS provider will meticulously take note of several key elements. These include the patient's approximate age and apparent sex, their overall body position, e.g., supine, prone, seated, tripod, and any immediately obvious signs of distress or overt trauma, such as significant bleeding, deformities, or unusual posturing. Crucially, this initial assessment extends beyond the patient themselves to encompass a rapid evaluation of the surrounding environment. The context of the scene can provide invaluable clues that significantly inform the provider's initial understanding of the situation. Is the patient located within a vehicle, potentially indicating a motor vehicle collision and associated mechanisms of injury? Are they found lying on a sidewalk, raising questions about possible falls, assaults, or medical emergencies occurring in a public space? Are they sitting on a couch within a residence, perhaps suggesting a medical issue that developed at home? The provider will also be vigilant for any indicators of potential contributing factors, such as signs of violence, e.g., broken objects, weapons, evidence of possible drug use, e.g., paraphernalia, unusual odors, or the presence of medical equipment, e.g., oxygen tanks, medications, that might offer insights into the patient's medical history. The significance of a strong and accurate general impression cannot be overstated. It serves as an early warning system, potentially allowing the EMS provider to identify immediately life-threatening conditions even before a hands-on, detailed assessment commences. For instance, encountering an unresponsive patient slumped over the steering wheel following a motor vehicle collision instantly elevates the priority of this case to the highest level, prompting immediate interventions focused on airway, breathing, and circulation. Similarly, the patient's posture and facial expressions can be remarkably revealing. An individual sitting upright and forward, often clutching their chest with a look of anguish, strongly suggests potential cardiac distress. Conversely, a patient who presents as pale, diaphoretic, sweaty, and lying completely still might be exhibiting early signs of shock, demanding rapid identification and management of the underlying cause. Furthermore, the general impression incorporates both visual and auditory cues. The EMS provider will be actively listening for any sounds emanating from the patient, such as moaning, gasping, stridor, or complete silence, each potentially indicating a critical issue with their airway or breathing. Visual assessment of their breathing pattern is equally vital. Is their breathing labored, shallow, rapid, or absent? Are they using accessory muscles to breathe, a sign of significant respiratory distress? All of these seemingly disparate elements, the patient's presentation, their immediate environment, and the visual and auditory information gathered in those initial seconds, coalesce to form the foundational general impression. This crucial first step acts as a filter, guiding the EMS provider's subsequent steps in the primary assessment, prioritizing interventions, and ultimately shaping the trajectory of care for the patient in their moment of need. Following the crucial initial step of forming a comprehensive general impression, the immediate next priority in the primary assessment is the rapid and accurate determination of the patient's level of responsiveness. To facilitate this critical evaluation of neurological status, EMS professionals universally employ the AVPU scale, an acronym that stands for alert, verbal, pain, and unresponsive. This seemingly simple yet remarkably powerful tool provides a standardized and efficient method for responders to quickly gauge the patient's current state of consciousness and the overall functionality of their central nervous system. When a patient is classified as alert, it signifies that they are awake, spontaneously interacting with their environment, and oriented to person, place, and time, though this level of orientation is often assessed in a more detailed secondary assessment. They will typically be able to answer questions appropriately, follow commands, and demonstrate an awareness of what is occurring around them. If a patient only responds to verbal stimuli, this indicates a decreased level of consciousness. They may open their eyes, make sounds, or move when spoken to in a normal tone or even when shouted at. This suggests that their brain is still functioning to some degree, but is not at their baseline level of alertness. A further decline in responsiveness is indicated when a patient only responds to painful stimuli. This assessment involves the application of a brief, controlled, and standardized painful stimulus, such as a sternal rub, firm pressure applied to the breastbone with knuckles, a trapezius pinch, pinching the muscle at the base of the neck, or pressure applied to the nail bed. A response might include a groan, withdrawal from the stimulus, or purposeful movement. Responding only to pain signifies a significantly depressed level of consciousness and warrants serious concern. Finally, if a patient is unresponsive to all forms of stimulation, neither verbal nor painful, this represents a critical and potentially life-threatening situation. An unresponsive patient exhibits no spontaneous movement, makes no sounds, and does not react to any external stimuli, indicating a severe compromise in brain function. Accurately determining the patient's AVPU status immediately upon contact is paramount as it directly influences the subsequent priorities of care. For instance, an unresponsive patient or one responding only to pain may necessitate immediate interventions such as advanced airway management to secure and protect their airway and ensure adequate oxygenation. The AVPU scale also plays a vital role in guiding decisions regarding the urgency of transport to a definitive care facility. A rapidly deteriorating level of responsiveness, or a consistently depressed level, often necessitates immediate transport to a hospital capable of providing advanced neurological care. Furthermore, the initial AVPU assessment serves as a critical baseline against which all subsequent reassessments are compared. Regularly reassessing the patient's level of responsiveness throughout care allows EMS providers to continuously monitor for any improvement or decline in their neurological status, providing valuable information about the effectiveness of interventions and the overall trajectory of the patient's condition. Identifying the patient's chief complaint stands as a fundamental cornerstone of any focused assessment and the subsequent development of an appropriate care plan. Essentially, the chief complaint represents the primary reason why the patient, or in some cases bystanders, initiated the call for emergency medical services. It is the patient's own articulation of what is bothering them most, or the most apparent issue observed by others. Common examples of chief complaints include chest pain, shortness of breath, various forms of trauma resulting from injury, or an observed altered mental status. For a conscious and coherent patient, eliciting the chief complaint is typically achieved through a direct and open-ended question, such as, "What seems to be the problem today?" This allows the patient to describe their symptoms in their own words, providing valuable initial insight into their condition. However, the process of determining the chief complaint becomes more complex when the patient is unconscious, significantly confused, or otherwise unable to communicate effectively. In such situations, the astute EMS provider must rely on alternative sources of information. This often involves actively engaging with any family members, friends, bystanders, or first responders who are present at the scene. Gathering their observations about what occurred, the patient's prior condition, and any specific complaints they may have heard can be crucial in forming an initial understanding of the situation. Furthermore, The environmental clues identified during the general impression take on even greater significance. For example, finding an empty medication bottle near an unconscious patient might suggest a possible overdose, while evidence of a fall could indicate trauma as the primary concern. The accurate identification of the chief complaint is absolutely crucial as it allows the EMS professional to strategically focus their subsequent assessment efforts on the body systems most likely to be involved in the patient's current medical or traumatic issue. For instance, if the chief complaint is chest pain, the provider will prioritize a detailed assessment of the cardiovascular system, including vital signs, cardiac monitoring, and inquiries about associated symptoms. Conversely, a chief complaint of shortness of breath will necessitate a more in-depth evaluation of the respiratory system, focusing on breathing rate, depth, effort, and lung sounds. This targeted approach ensures efficiency and allows for the rapid identification of critical findings. Moreover, a clear understanding of the chief complaint is paramount in prioritizing treatment interventions and making critical decisions regarding the necessity of rapid transport to a medical facility versus initiating more extensive stabilization measures on scene. The chief complaint essentially acts as the initial compass, guiding the EMS provider through the assessment process and towards the most appropriate and timely care for the patient. Airway assessment stands as the absolute foundation of all life support interventions, underscoring its critical importance in emergency medical care. The rationale is stark and unequivocal. A blocked or compromised airway will inevitably lead to hypoxia, brain damage, and ultimately death if not recognized and managed swiftly and effectively. The initial step in this assessment is often deceptively simple. If the patient is speaking clearly and in full sentences, it can be reasonably assumed that their airway is currently patent and unobstructed. However, the absence of clear speech, or any alteration in voice, immediately raises a red flag and necessitates a more thorough evaluation. The EMS provider must meticulously check for telltale signs of airway obstruction, which can manifest as abnormal sounds such as gurgling, often indicating the presence of liquid in the airway, snoring, suggesting a partial obstruction by the tongue, or stridor, a high-pitched, whistling sound indicative of a significant upper airway narrowing. To physically open and maintain a patent airway, EMS providers are equipped with fundamental manual techniques. For patients without suspected cervical spine injury, the head tilt, chin lift maneuver is typically the first-line approach. This involves gently tilting the patient's head back while simultaneously lifting the chin forward, which helps to lift the tongue away from the back of the throat. In situations where cervical spine injury is suspected, often indicated by the mechanism of injury in trauma patients, the jaw thrust maneuver is the preferred method. This technique involves carefully placing the fingers under the angles of the mandible, lower jaw, and lifting it forward and upward without extending the neck. This maneuver also helps to displace the tongue without risking further spinal cord injury. If an airway obstruction is identified, immediate intervention is paramount. This may involve the use of suctioning equipment to remove liquids such as blood, vomit, or secretions from the airway. In cases of visible solid obstructions, such as foreign bodies, manual removal using techniques like finger sweeps, performed with caution to avoid pushing the object further down, may be necessary. In the context of trauma patients, maintaining strict cervical spine precautions throughout the airway assessment and management process is absolutely critical. Any unnecessary movement of the neck could potentially exacerbate a spinal cord injury. Therefore, airway maneuvers must be performed with meticulous inline stabilization of the cervical spine, often with the assistance of a trained team member. Securing a clear and protected airway in trauma patients may necessitate the use of more advanced airway adjuncts. Oropharyngeal airways, OPAs, are rigid plastic devices inserted into the mouth to keep the tongue from obstructing the airway in unconscious patients without a gag reflex. Nasopharyngeal airways, NPAs, are soft, flexible tubes inserted through the nose and into the pharynx, and can often be tolerated in semi-conscious patients. In situations requiring more definitive airway management, and when trained personnel, such as paramedics or advanced EMTs, are available, Endotracheal intubation. The insertion of a tube directly into the trachea may be performed to provide a secure and protected airway, allowing for mechanical ventilation if needed. The choice of airway management technique is dictated by the patient's level of consciousness, the presence of a gag reflex, the suspected mechanism of injury, and the skill level of the EMS providers on scene. Regardless of the technique employed, the overarching goal remains the same: to establish and maintain a clear and patent airway to ensure adequate oxygenation and prevent irreversible neurological damage or death. Following the establishment and confirmation of a patent airway, the immediate next critical step in the primary assessment is a thorough evaluation of the patient's breathing. This assessment goes beyond simply noting the presence or absence of respiration. It involves a detailed analysis of the rate, rhythm, and overall quality of the patient's breathing efforts. Any significant deviation from normal parameters in these areas can indicate underlying respiratory distress or failure, potentially necessitating immediate ventilatory support. For instance, breathing that is excessively fast, tachypnea, or abnormally slow, bradypnea, breaths that are shallow and ineffective, or breathing that appears labored, involving the use of accessory muscles in the neck, chest, and abdomen, all signal potential compromise in the patient's ability to adequately oxygenate and ventilate. In cases where breathing is completely absent, apnea, immediate and aggressive intervention is required. To accurately assess the adequacy of air exchange, EMS workers utilize a combination of physical examination techniques, objective monitoring tools like pulse oximetry, and sometimes auscultation, listening to lung sounds with a stethoscope. During the physical examination, the provider will observe the rise and fall of the chest, noting its symmetry and depth. They will also look for signs of increased work of breathing, such as nasal flaring, retractions, pulling in of the skin between the ribs or above the clavicles, and the use of abdominal muscles to assist with respiration. Pulse oximetry provides a non-invasive measurement of the patient's peripheral oxygen saturation, SpO2, indicating the percentage of hemoglobin in the red blood cells that is carrying oxygen. While a valuable tool, it's important to remember that pulse oximetry can be influenced by factors such as poor perfusion, and it doesn't provide information about the adequacy of ventilation, carbon dioxide removal. Auscultation of lung sounds can reveal the presence of abnormal sounds such as wheezing, suggesting bronchoconstriction, crackles or rowels, indicating fluid in the small airways, or rhonchi, suggesting secretions in the larger airways, all of which can provide further insight into the underlying respiratory pathology. Based on the comprehensive findings of the breathing assessment, the EMS provider will determine the appropriate level of oxygen therapy or the need for assisted ventilation. For patients who are breathing spontaneously but exhibiting signs of hypoxia, low oxygen saturation, or respiratory distress, supplemental oxygen may be administered. Nasal cannulas are typically used for patients with mild to moderate hypoxia who can tolerate a lower flow of oxygen. Non-rebreather masks, which incorporate a reservoir bag and one-way valves, can deliver higher concentrations of oxygen to patients with more significant hypoxia while still breathing independently. For patients who are not breathing adequately, too slow, too shallow, or absent, or those exhibiting signs of impending respiratory failure, assisted ventilations using a bag valve mask, BVM, connected to an oxygen source are crucial. The BVM allows the EMS provider to manually deliver positive pressure ventilation, ensuring adequate tidal volume and oxygenation until more definitive airway management can be established, if necessary. The choice of oxygen delivery device or the decision to initiate assisted ventilation is a dynamic one, based on the continuous reassessment of the patient's respiratory status and their response to initial interventions. Following the critical assessments of airway and breathing, the next crucial component of the primary assessment is the evaluation of the patient's circulation. This multifaceted assessment focuses on ensuring adequate perfusion of oxygenated blood to the vital organs and involves systematically checking for major bleeding, evaluating the characteristics of the patient's pulse, and assessing the color, temperature, and condition of their skin. The very first priority within circulation assessment is to rapidly identify and control any life-threatening external hemorrhage. Uncontrolled bleeding can lead to rapid hemodynamic instability and death. EMS workers are trained to immediately scan the patient for obvious signs of significant blood loss and to employ appropriate hemorrhage control techniques. Direct pressure applied directly to the bleeding site remains the cornerstone of initial management. For severe extremity bleeding that cannot be controlled with direct pressure alone, tourniquets are applied proximal to the injury to occlude arterial blood flow. Hemostatic agents, often in the form of granules or dressings, may be used in conjunction with direct pressure to promote clot formation, particularly in areas where tourniquet application is not feasible or effective. Once immediate life-threatening external bleeding has been addressed, the EMS provider will proceed to evaluate the patient's pulse. This involves palpating a central pulse, such as the carotid artery in the neck or the femoral artery in the groin, to determine its presence. If a central pulse is not readily palpable, it often indicates a critical state of hypoperfusion or cardiac arrest. If a pulse is present, the provider will then assess its rate, too fast, too slow, or within the normal range, its rhythm, regular or irregular, and its quality or strength, bounding, strong, weak, or thready. A rapid, weak, and thready pulse can be an early indicator of hypovolemic shock, inadequate blood volume, while a slow and bounding pulse might suggest bradycardia or increased intracranial pressure. An irregular pulse could indicate an underlying cardiac dysrhythmia. Simultaneously, the assessment of the patient's skin provides valuable insights into their circulatory status and overall perfusion. The EMS provider will observe the skin color, noting any pallor, paleness, which can suggest poor perfusion or anemia. Cyanosis, a bluish discoloration, particularly around the lips and nail beds, indicating inadequate oxygenation, or flushing, redness, which might be associated with fever, allergic reactions, or carbon monoxide poisoning. The skin temperature is also assessed, typically by feeling the patient's forehead or extremities. Cool or cold skin, especially when accompanied by pallor and clamminess, moist and sweaty, is a classic sign of hypoperfusion and the body's compensatory mechanisms in response to shock, where blood is shunted away from the periphery to the vital organs. Conversely, hot and dry skin might suggest fever or heat stroke. The skin's condition, whether dry or moist, also contributes to the overall assessment of the patient's circulatory status and hydration level. These findings, in conjunction with the pulse assessment and the presence or absence of bleeding, provide a comprehensive picture of the patient's circulatory system and guide further interventions aimed at optimizing perfusion and addressing any underlying circulatory compromise. Following the systematic assessment and initial management of the patient's airway, breathing, and circulation, the ABCs, a critical decision point arises: determining the appropriate transport priority. This decision is not made in isolation but rather is a dynamic process influenced by a constellation of factors, all aimed at ensuring the patient receives the most appropriate level of care in the most timely manner. Several key elements weigh heavily in this crucial judgment. The patient's overall condition and the severity of their presenting problem are paramount. Patients exhibiting immediately life-threatening conditions, such as significant respiratory distress, uncontrolled hemorrhage, signs of severe shock, unresponsiveness without a clear reversible cause, or ongoing seizures, are classified as high priority and necessitate immediate and rapid transport to the nearest appropriate medical facility. The urgency in these situations stems from the need for definitive medical or surgical intervention that cannot be provided in the pre-hospital setting. The findings from the primary assessment, including the AVPU level, breathing rate and quality, pulse characteristics, and skin condition, are critical in identifying these high-acuity patients. The geographical context, specifically the distance to the closest hospital equipped to handle the patient's needs, is another significant factor. In rural settings or areas with limited access to medical facilities, even a seemingly stable patient might warrant expedited transport due to the potential for deterioration during a prolonged transport time. Conversely, in urban areas with multiple nearby hospitals, the decision might involve a more nuanced consideration of the specific capabilities of each facility. The capabilities of the receiving medical facility are a crucial determinant of the transport destination. Not all hospitals offer the same level of care. For instance, a patient experiencing a suspected stroke would ideally be transported to a designated stroke center with specialized neurological services. Similarly, a patient with significant trauma might require transport to a trauma center equipped with surgical teams and resources to manage complex injuries. EMS protocols and regional guidelines often dictate the appropriate destination based on the patient's suspected condition and the available resources within the healthcare system. Understanding the capabilities of local hospitals, including their expertise in cardiac care, neurosurgery, pediatrics, and other specialties, is essential for making informed transport decisions. In situations where the patient's condition warrants a higher level of medical intervention than basic life support, BLS, ambulances can provide, EMS providers may request advanced life support, ALS, intercept. This involves paramedics or other advanced practitioners meeting the BLS unit en route to provide interventions such as advanced airway management, e.g., endotracheal intubation, cardiac monitoring and defibrillation, and the administration of a wider range of medications. The decision to request ALS is based on the patient's clinical presentation and the anticipated need for these advanced therapies. Crucially, the decision regarding transport priority is not a static one. Throughout the duration of transport, ongoing reassessment of the patient's condition is absolutely vital. The EMS providers will continuously monitor the patient's vital signs, level of responsiveness, and any changes in their presenting symptoms. This continuous evaluation allows for the early detection of any deterioration or improvement in the patient's status, potentially necessitating an adjustment in the transport priority or destination. For example, a patient initially deemed stable might decompensate en route, requiring a more urgent transport status and direct communication with the receiving hospital. Conversely, a patient's condition might improve following initial interventions, although continued monitoring and transport to an appropriate facility remain necessary. This dynamic and continuous reassessment ensures that the patient's needs remain at the forefront of the decision-making process throughout the entirety of the EMS encounter. The primary assessment in emergency medical services represents the critical initial phase of patient evaluation, a rapid yet systematic process designed to swiftly identify and address any immediate threats to life. It commences with forming a comprehensive general impression, a crucial step that involves a rapid visual and environmental survey to detect obvious life-threatening conditions and gather initial clues about the nature of the emergency. This windshield survey allows the EMS provider to immediately prioritize interventions and anticipate potential issues. Following this initial overview, the next priority is to determine the patient's level of responsiveness using the standardized AVPU scale: alert, verbal, pain, unresponsive. This neurological assessment provides a quick gauge of the patient's central nervous system function and helps guide immediate management decisions, such as the need for airway support. Subsequently, identifying the chief complaint, the primary reason for the EMS call as stated by the patient or observed by others, becomes the focal point for directing further assessment and treatment strategies. This information helps to narrow the scope of the examination and prioritize the most likely underlying issues. The assessment of airway and breathing is fundamental to survival. Ensuring a patent and protected airway is the absolute priority, followed by evaluating the rate, rhythm, and quality of the patient's respirations. Based on this assessment, appropriate interventions, such as manual airway maneuvers, suctioning, or the administration of supplemental oxygen via various delivery devices, are initiated to optimize oxygenation and ventilation. Next, the circulation is meticulously evaluated. This involves first and foremost checking for any signs of major external hemorrhage, which must be controlled immediately using techniques like direct pressure, tourniquets, or hemostatic agents. Following hemorrhage control, the pulse is assessed for its presence, rate, rhythm, and quality, providing insights into the patient's cardiac output and perfusion status. Finally, the skin's color, temperature, and condition are examined for indicators of adequate or inadequate perfusion, such as pallor, cyanosis, coolness, or clamminess, which can suggest underlying shock. Based on the integrated findings of the primary assessment, EMS providers must then make informed treatment and transport decisions. This involves considering the severity of the patient's condition, the estimated transport time to an appropriate medical facility, and the specific capabilities of the receiving hospital to address the patient's needs. High-priority patients with life-threatening conditions necessitate immediate and rapid transport. Furthermore, throughout the entire patient encounter, and critically during transport, ongoing reassessment is paramount. The patient's condition can change rapidly, and continuous monitoring of vital signs, level of consciousness, and the effectiveness of interventions is essential to adapt the care plan and ensure the best possible outcome for the patient. This dynamic and iterative process of assessment, intervention, and reassessment forms the core of effective pre-hospital emergency care. Thank you for completing this lesson. We hope you found the course informative and valuable. Please proceed to the post-test to assess your knowledge of the topic. And that you for visiting EasyEMSSU.com.